This time the VLE participation is on the overall semester's reflection. So I'll be basically running through all the lessons that we have learned during this semester under the module of health economics. And to begin with, the first we learned why health economics, and under this chapter we learned the reasons for why we learn health economics, how it is important to learn, and how it relates with our real scenarios. So why it is important. So basically, health leads to economic growth, which we all know, and it is a very logical thing because if your health is good, you will perform better, and if you perform better, then you will earn better, and as you earn better, you can do better in life. As you do better in life, you contribute better in the in country. So basically the labor productivity comes in, and as labor productivity increases, the country's economic growth also increases. So it's basically related with the whole economy. One individual making a difference to the whole economy. So now going to the lessons. First we learned with demand for healthcare, like why do we demand for healthcare, or we also question here under this topic. We had one question, which is like, is the demand for healthcare a downward sloping, which means the price sensitivity comes in. So here we learned of three main topics under demand for healthcare. First is the price sensitivity, second is the trade-off in healthcare systems, then third is the Grossman model. And price sensitivity, under this we learned about the different experiments that the US actually under health economy we only looked at the US health system. So price sensitivity, under this we learned about the two experiments that the US did to know whether people are price sensitive towards the healthcare or not. So RAND, HIE, and Oregon Medicaid experiments were run. RAND HIE was like randomly picking people, and like they were checking people if they were basis on the insurance they were providing. For example, they were providing free insurance, they were providing co-payment insurance. Co-payments were starting from 25, 50, 75, and 95, in which they were seeing the difference between the people paying a different amount of money based on the insurance given, and they found out that people are sensitive towards price, as because like more people were willing to go for the healthcare, those who have free insurance, compared to those who have to pay 90% of their healthcare. So basically this experiment RAND AGI showed that people were sensitive towards the price. And then next, Oregon Medicaid, they were like, the situation was where people were given lottery winner and lottery losers were there, and lottery winners were like seen that they were more prone to get more healthcare and lottery compared to lottery losers. However, like not much significant, even though not significant result, but still then lottery winners were more of like uh prone to go to healthcare and compared to the lottery losers, which means the lottery winners basically did not have to pay from their pocket to have the healthcare access. So this showed that people were price sensitive towards the healthcare, and the trade-off in healthcare systems were that free healthcares, they lead to increased demand, and even for less useful cares as well. Like if people see free healthcare, even if the utility that they would derive from those healthcare were less, they would be willing to go because it's free. And while paid healthcare may deter some from seeking necessary care, especially among the vulnerable populations. And Grossman model is basically a graphical representation of the price sensitivity, to check the price sensitivity of the people. And here, Grossman model also showed that health is considered a choice over a time and affected by small decisions. inclining with the declining marginal productivity of health investment and time constraint. Now, to talk more on the Grossman model, Grossman model is says that health as an investment where individual will allocate their resources to maintain or to improve their health, and health is also considered as it is also treated as a durable capital stock that depreciates over time, and investment in health can slow down its depreciation. Now, factors affecting the investment are endowments, where people start with different health endowment and they may or may not have a high degree of control over them. And now, health behavior here, the daily decisions such as exercise, diet, and preventive care contribute to the overall outcome. And education and information, it plays a major role here, because better educated people, they make more informed decisions regarding their health. Example, we can read some medicine names like paracetamols, and we know that this medicine is paracetamol and it's useful when we have headaches, and we use citizens whenever we have like fever or anything and we have trouble sleeping due to the fever, we can take that. But we're not educated, which means obviously you can't read, so the prescribed medicines are not useful. So the Grossman model also explains about the declining marginal returns, where capital investment, as in health, there is a diminishing return, and individual which invest more in health, their marginal gain will decline. And implications are there that in the Grossman model that says that health and aging, where the model predicts that health investment earlier in life can have significant impact on health outcomes during aging. And labor leisure trade-offs, where individuals make choices about how to allocate time between work and leisure, and health investment can impact these choices, influencing a labor leisure trade-offs. So all this explains the Grossman model, and Grossman model also shows that healthcare is a downward sloping curve. Then next we came to the topic. We learned the topic on socioeconomic disparities in health. We questioned that there were many theories which say, such as efficient producer hypothesis, thrifty phenotype hypothesis, direct income effect, allostatic load hypothesis, productive time hypothesis. All this evidences showed that better educated peoples are more efficient in producing health, and early life health events significantly impact our lifelong health. And it also showed that richer people are able to acquire more of quality healthcare, and compared to poor, low income group people. Then the third topic that we learned is under the supply of healthcare. First is physician labor market, where physicians, before they become physician, they have to studying, and they have to invest a lot of money in studying. After that, they do not become physicians directly. They have to go through a training, and in that training period, they have to pay as well, and from that only they are being um, said that they are physicians, and they have a very um, tedious journey to become a physician, and a lot of money is required as well. So physician shortages occur because it is very expensive, first of all. Second of all, it is very tough subject because it requires a lot of years to be invested in. So physician shortages comes, and then barriers to entry due to expenses, then specialized residencies, then due to a specific specialty promptly affecting the physician supply and all. Then under that we learned about the uh, physician. We say we in this physician industry, we question one thing, that is, are the physician the right person for your healthcare? We Under this we looked into the physician induced demand, where some physicians to increase their profit, they make you like go through some tests which are not required for your health issues, because health issues, and you just follow what they are saying. So they induce demands and they earn profit through it. And then hospital industry, under this we learned about the technology advances. And under it is the hospitals which evolved into technology marvel. They compete, the hospital not only compete within themselves through price, lowering the price, but they compete with the quality of technology. So as one hospital increases the technology, another obviously advances the technology, which means they have a competition between the health technologies. But this causes a social welfare loss, uh, because we know that um, I mean, the more the advanced technology the hospital uses, the more expenditure is imposed on the patients. And here government here we learned about the medical armrest hypothesis, which measures how the hospitals are which hospitals is, higher the medical armrest hypothesis is, the the bad influence it will have on the society. Then government policies are also adopted to address the market power issues, and also to like look into the issue of equity in healthcare. Then we learned about the demand for insurance. Here we learned that demand for insurance, why people demand for insurance, why some people demand for insurance. And here we learned the important thing that we learned is diminishing marginal utility, where it explains that the demand for insurance and the risk aversion beyond income, it extended to various decisions made under uncertainty. So some people take insurance because of uncertainty. Some people are risk averse in nature, so that's why they take into the insurance. And example like insurance like for Marilyn and diet rich legs like medical patients, a risk reduction strategy, and large family size in developing countries linked to high infant mortality risks. So that's why they take into the consideration of the um, having the insurance for themselves. Then we came up with the topic of adverse selection. Ar- Akerlof's market for lemons. Here we learned about the asymmetric information, where asymmetric information, as in seen in use of the car market, which is also useful in insurance market, and where uncertainty can lead to market failure, and quality guarantees and market stability. Under here, markets may not unravel if buyers value the product enough, or if credible minimum quality guarantees exist, which means higher quality goods are never being sold. They sell only the lower quality goods, and they check whether the buyers value the cars more than they do, then only they are able to sell it. So here the risk aversion, it may challenge the result of the Arkulov model, as highly risk averse buyers might purchase insurance if it's not beneficial. Then adverse selection, like here Rothschild and Stiglitz model. Under this we learned about the pooling equilibrium, where no pooling equilibrium exists in insurance market, as preventing will enable the individual from subsiding the frail individuals, and separating in equilibrium. Here the frail individuals might be fully insured but pay higher premiums, so while enabling the individuals are, while robust individuals are partially insured but pay low premiums. And insurance market dynamics, here insurance company will doesn't don't offer the bulk discounting, and separating equilibriums maintain a differentiated premium. Then After learning so much about the healthcare system and all, we have to know moral hazard is one of the most important thing that has to be taken care in the healthcare, because moral hazard is one of the prevalent issues uh, that is happening in the health issues, where it has an impact on insurance scheme, where moral hazard will challenge both the private and public insurance scheme, leading to cost sharing provisions and incomplete coverages. It challenges the information, where insurer and the government struggle to differentiate the appropriate and inappropriate care, leading to incomplete insurance product. Then we learned about the health and the technology. Under this, we learned how the technology is being used and how technologies are, and in what terms the technologies are good and bad to the society through the healthcare. So here, firstly, balancing cost and benefit. Here, the evolving role of drugs like aspirin and newer medications like Pelvix raises question about balancing cost and benefit in medical innovation. So before we jump into that, we have to know that the drugs that are in the market, before they come into the market, they have to go through a various stages. Then only they are able to come into the market. And after they have been like approved for the market distribution, they are being provided with a property right, because for their innovation and for further innovation as an incentive to them. And here, the coverage discussion for new drugs highlights the dilemma of societies facing regarding the cost and benefits of the medical discoveries. Then technology is also seen as the tool for controlling moral hazard, because it is essential for insurers to make decisions about coverage, balancing effectiveness and cost. Then controversies in coverage. Here, examples like Oregon Medicaid program illustrated that the controversies and public backlash surrounding selective coverage decisions. And under health policy, we learned about the complexity of um, health policy. And here, complexity was basically addressing the information asymmetries and trade-offs between the equity, efficiency, cost present a challenge in the health policies. Then there is a trade-off in policy, where balancing equity, efficiency, cost in health policy leads to a dissatisfaction among citizens, as in people in various countries, due to differing priorities. So each topic that I have stated and like provided um, some insight to it, have a very critical aspect of the overall like reality of the healthcare system, and relating with the economy, and how the insurer and the governments are providing a comprehensive and effective healthcare coverages. So over these were the overall topics that we learned in the class during this semester under the health economics. Thank you.